Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of August 1st, 2022. It is hard to believe, but school is going to be starting in a lot of places in about a week. And so today we're going to talk a little bit about children and COVID, and also I'll provide a little update on President Biden's bout with COVID, as well as a monkeypox update. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. As you can see here, cases in Alameda County do appear to be coming down. Those last few days will continue to be updated, but it looks a little promising that we might be seeing a decrease. Same thing when we look at the 14-day average. We were a little over 10,000 when I reported last week, so we are headed in the right direction here. And same thing with our 7-day percent positive tests. We are also heading in the right direction, which is good news. Unfortunately, hospitalizations still continue to creep up. We were at 146 people in the hospital when I reported last week, and now at 167. But remember, hospitalizations tend to lag behind cases, and so we aren't sure where we'll see a peak there, but we'll continue to keep an eye on that. In terms of nationwide, we're still seeing around 420 people a day dying from SARS-CoV-2, about 3,000 per week. So that would amount to over 150,000 people per year. So still a pretty high ongoing death toll from COVID-19. And we're still continuing to see about the same number of people admitted to the hospital every day, around 5,900. And so these are obviously still causing quite a major burden in terms of illness and death. And in terms of who is dying in the state of California, the last full week reported here, we're still showing that unvaccinated individuals are 9.4 times more likely to die of SARS-CoV-2 than those who are boosted. And in terms of the variants we're dealing with, it's pretty much all about the BA.5 subvariant, which I've been reporting on for a while now. We're at 82% of our cases nationwide being attributable to BA.5, and that is pretty much going on across the country. So turning a little bit to our little ones and SARS-CoV-2, we know they're getting ready to go back to school, and one of the big concerns is that a lot of the mitigation strategies that were in place last year may not be in place this year. So the mask requirements were going away in many places, although Oakland Unified did maintain it quite a bit longer than other places. We'll see what the policies will be for this new year. But we know that even though children tend to fare better, SARS-CoV-2 is not benign in our children. And I'll talk a little bit more about what I mean by that, but we'll start off with the largest toll in terms of numbers as it affects our children, has to do with the number of children who've lost their parent or their primary caregiver. And so that number sadly just kind of continues to tick up. We have now 221,000 children who have lost their primary caregiver. So this is a tragedy all by itself. There are 206,200 children who have been orphaned by COVID. So this is devastating, traumatic. So that doesn't even get into the direct impacts of COVID on our children. And that is that we do have children who have gotten sick enough to be hospitalized and die from SARS-CoV-2. What we are seeing is that we've had 1,325 children who have died from COVID-19. That is an increase of about 112 from when I reported on this 2 months ago at the end of May. And just by way of comparison, that is compared to 34 from the flu in that same time period. So from January of 2020 till now, 34 have died from flu. So 1,325 from COVID, 34 from flu. And remember that we've had more of our child COVID deaths in 2022 than any other time period in the pandemic. So this, of course, gives us concern as we head into yet another school year about wanting to continue to protect our children to the best of our ability. There's also another 8,639 children who have died from MIS-C. So that is that inflammatory condition that happens after COVID. So more than 8,600 children getting that condition that lands about a third to a half of them in the pediatric ICU, and 70 children have died from that kind of post-COVID effect of MIS-C. So that's in addition to the 1,325 that died directly from the acute COVID infection. So this is not benign by any means. It is by far the top infectious cause of death in children in the United States, and continues to be. And we have over 300 new hospital admissions on our 7-day average for children. So this is 0 to 17 years old. So this is still clearly causing a burden. And you can see here on the hospitalization for our 0 to 17-year-olds that hospitalizations are going up, just headed right in the wrong direction. This is nationwide. And this is, of course, concerning because school hasn't even started yet. The other thing I wanted to point out is that we do have very significant racial disparities among our children, our pediatric deaths in both the 0 to 4 and the 5 to 18 age ranges. African American children are comprising 25% of the pediatric deaths. So that's despite being only 12% of population. So this is double what we would expect. And so these disparities are a tragedy all by themselves, and something that we absolutely need to get a better understanding of, and really do a better job at protecting all children, but particularly the ones that we know are vulnerable. And as it relates to the sort of mysterious hepatitis of unexplained origin in children, I reported on this more extensively also at the end of May. And at that time, there were 180 cases in the United States. Now we're at 354. So this is hepatitis that is causing quite a bit of liver failure. There's now over 1,000 cases worldwide. It was 600 when I reported 2 months ago. There are 35 countries reporting, but most of the cases are in the UK and the US, which are also where a huge share of our COVID cases have been. We now have 22 children who have died. It was at 6 before, but now we have 22 children who have died from this liver failure, and 46 who have gotten liver transplants. So this represents about 5% of the children who are getting this hepatitis. And so I'm not going to get into a lot of the theories about what it is that is going on with this, but I think that there is definitely an effort to try to better understand this. We are definitely, it looks to be a potential post-COVID, or perhaps post-COVID plus another virus on top of it, virus that doesn't normally cause liver failure. So there's still a lot to learn here, but certainly I think this is a big cause for concern because it is still an evolving situation. It's an ongoing investigation that we frankly don't hear a lot about, but I wanted to bring it up here because these cases are continuing to be reported. Not all countries are reporting or have the sort of surveillance systems to do this. And really, it has been a sort of disappointing, I think, chain of events around this hepatitis because of all of the, I think, confusion and also not a lack of clarity on the best way to treat it. But the way that most countries seem to be focusing on this is that it is post-COVID, there is inflammation going on, steroids are appropriate treatment, and we want to prevent it from getting to liver failure requiring a transplant, because 5% is actually quite a bit of needing an organ transplant and immune suppression for life. And so this definitely will affect life expectancy and quality of life for these young people. And as we sort of head into another school year, I think this is something that we want to be thinking about because there's still a lot that is unknown. The other part that is still unknown has to do with other types of post-COVID or long COVID impacts. And so we know that in children, even when they had a mild case or even an asymptomatic case, that there can be lingering effects afterwards. And so that hepatitis may be another form of that. So bottom line is that children should be protected from infection, and they should be protected from infection with vaccination. The benefits of vaccination are absolutely clear in reducing the risk of severe COVID, and most of the severe outcomes from COVID, including these pediatric hepatitis cases, have been more in unvaccinated children. And so we still have a lot to learn about the impact of vaccination on all of these other long COVID, post-COVID, et cetera. But there's no question that it can reduce those severe outcomes and also reduces the chance of getting it in the first place. And so when it comes to vaccination here in Alameda County, we are continuing to see progress. Our 5 to 11-year-olds, we have 68.4% that have been vaccinated. Our 12 to 15-year-olds and our 16 to 17-year-old, that's really getting so much higher now. We're at 89, 90% vaccinated in that 12 to 17-year-old group. So that is great to hear, or have received their first dose. 5 to 11-year-olds at 68% have received one dose, and 6 months to 4-year-olds, over 18% have received their first dose. And so certainly as school's getting ready to start, definitely a good time to make sure that our children are up to date on all of their vaccines. And there is just no question that COVID vaccine needs to be among those, because like I said, this is the leading infectious cause of death in our youth age groups. And we now have a way to protect them. And so, and we have not seen any downside, which is, quite remarkable in terms of how many doses have been administered already. And so we're over 600,000 doses having been administered in the United States in this age group. Still no safety signals, and we know that it is protective. And so that is something to definitely keep in mind as we head into the school year. The other things are the masking, making sure there's good ventilation in the schools. Very hopeful that the testing programs will be in place. But definitely, if your child is not feeling well, please keep them home. We know it's difficult. This is not easy, but unfortunately, this is still highly contagious, even more contagious than what we were principally dealing with at the end of the school year. And so now would be the time to invest in some good, comfortable masks for our young people and really consider having them wear them. Definitely keeping them home if they're not well, testing them if they've had any exposure or if they have any symptoms, and making sure that we protect them from getting this transmissible illness, not to mention the next transmissible illness, which I will talk about in just a few moments. But first, I'm going to talk about President Biden. I talked about him last week and about how I wasn't feeling very happy with the display of him pushing through at work, not masked, while he was positive with SARS-CoV-2. He then took the Paxlovid, which is great, felt fine, and tested negative for a couple of days, and then bam, he tested positive again. And so I talked about the rebound phenomenon in detail in the July 12th briefing. So if you are interested in that, go ahead and check that out. But I think what I want to say about Rebound is, first off, we know it is not unique to people who take Paxlovid. It's been shown to happen with molnupiravir, the other oral treatment, and even in people who were not treated at all. Even the placebo group in the original Paxlovid trial showed rebound. But also, Paxlovid is preventing serious illness and death from COVID. So this rebound phenomenon does not change that at all. And I referred to a very large study of 92 million patients. I talked about that in July 12th, so I won't go over it in detail here, but bottom line with this is that there were rebound infections at 7 days and at 30 days after treatment, but the hospitalizations remained very, very low. And so there is absolutely no evidence that the rebound phenomenon itself means that there's any kind of poor outcome that happens from it, but it is very inconvenient. You do test positive again, and you are presumably contagious again. I also went over the fact that there are several studies that have provided us reassurance so far that rebound has nothing to do with drug resistance. So not saying that couldn't happen in the future, but so far the rebound that we're seeing does not seem to be due to any kind of drug resistant mutation. So that is a big major relief. But we still have a lot to learn here. Just about COVID and its own natural history. So how many days is there, what does it mean when people turn positive again? Does it mean that they're failing to clear the virus in the short term, or they're just taking longer? Could they have been reinfected, or is this really a recurrence? It does look like it is just a recurrence in most of these cases, but we haven't really monitored for very long. So what happens after the 30 days? The 30 days was kind of an arbitrary thing that was looked at in the study that I mentioned, but we're going to need more study to truly, truly understand this. And to understand, is this prolonged, of having this virus? Some people are testing positive for weeks, even with the antigen test. So remember, PCR, we expect to be positive for a long time, but the antigen, once you clear it, we expect it to turn negative. So what does this mean if you have a prolonged positive test? Does this relate in any way to long COVID? We just don't know that yet. And does the dose of medication need to be changed, or the duration of treatment need to be adjusted? We don't know that either. So I think the bottom line for this is 5 days means nothing. So I know that that's the CDC's guidance, but we really are going to sort of insist here that after the 5 days, please test. And actually keep testing after recovery, just to make sure, and especially right away if you get symptoms again. So if those symptoms return, you test again. If you test positive, you got to restart the isolation period. You are still contagious if you've got a positive antigen test. There's no reason to believe anything other than that. And the other thing I'll say is don't push it. Just don't push yourself if you have COVID. I really wish that we here in the United States in general we're better at taking time when we don't feel well, taking time off and recovering properly, and then testing to make sure you are negative before you then go back out into the world, back to work, etc. And so to the best of our ability, that is what I hope we are doing. And remember that the Paxlovid, the remdesivir, the monoclonals, all of those treatments are absolutely preventing hospitalization and death, and we do not want any more COVID deaths. This 420 people a day business is not acceptable. So no more COVID deaths means get vaccinated and boosted if you are eligible. If you're over 50 and it's been 4 months since your first booster, you can go ahead and get your second booster. Also, make a treatment plan. Figure out now if you're eligible for treatment, and that includes after you catch COVID, would you be treated? But also, are you eligible for Evusheld? If you are immune compromised, please talk to your doctor about Evusheld for 6 months of protection. If you don't have a primary care doctor, please get one and make sure you know how to reach them before you need them. So turning now to monkeypox, we are not done with our COVID pandemic, and yet we are now in another global health emergency. The World Health Organization has declared monkeypox a global health emergency. We now have over 23,000 cases and 10 deaths worldwide in this monkeypox outbreak. Keeping in mind, we know that it was It's been endemic in parts of Africa for quite some time. There have absolutely been cries for help and warning flags coming from our scientists in Africa prior to now, yet it was not dealt with. They do not have vaccines. And now we have a situation where everyone is paying attention because it has gotten into new areas where it was not previously found. We have 10 deaths now in this outbreak. 5 are in Nigeria, 1 in Ghana, 2 in Spain, 1 in Brazil, and 1 in India. And the last one is a 22-year-old, so a young person. We're not getting a ton of details about the deaths thus far, but this is obviously very concerning, especially because this initial population that this outbreak is in tends to be in younger men at this time. When it gets to little ones, that's when we get worried because it is more dangerous in children. And so this is why I was mentioning earlier about the precautions that we need to take for children when school starts. They don't only apply to COVID, they also do apply to monkeypox. This is not to cause any hysteria or anything like that, but we know that we are now unfortunately dealing with 2 global health emergencies. Here in the United States, we have over 5,800 cases now. So these are going up sharply. This is because also we're starting to test more, but not nearly enough. So we really don't know just how far this has gotten. But so far, we have 5,800 cases in the United States. We've got 3 states already that have declared this a state of emergency, and that includes here in California. Also, Illinois and New York have all declared it a state of emergency. This just helps us be able to respond more quickly. And we have here in California a Monkeypox Dashboard. This was last updated on July 28th, but it's showing 780 cases statewide, 11 individuals that have been hospitalized, and the top number of cases are in Los Angeles, followed by San Francisco, and then Alameda County so far is pretty far behind. We'll be continuing to keep a close eye on this. And so what do we need to know about this? So I think first off, the last 2.5 years, we've been dealing with an incredibly contagious airborne virus. And this is not contagious on the level of COVID. And so I will say that if you are adhering to the COVID-19 precautions in general, in terms of wearing a filtration mask out in public when you're in indoor settings, and also washing your hands, and distancing to, the extent possible, then this is generally going to prevent monkeypox from spreading in, at your work setting, on public transportation, things of that nature, because monkeypox spreads by close contact with the lesions, but it can happen through touching contaminated items like clothing, like linens, and so forth. So it's really more so in your personal life if you are very close, certainly if you're intimate, which is a type of close, but it's not the only type of close. If you touch someone's skin and they have the open sores, then you very much can catch monkeypox. So this is not a sexually transmitted infection. It can also be transmitted through respiratory droplets. So if you have prolonged face-to-face contact with someone and you're not wearing masks, then you could also catch monkeypox in this manner. But since we're being careful for COVID, that will be the same careful we need to be for monkeypox. And so in terms of symptoms, a lot of times there's sort of this viral kind of illness that comes before getting the rash. And so that could be like fever or headaches, muscle aches, and swollen lymph nodes, fever chills, fatigue, and then the rash. The rash can start out as small or flat little lesions, and then it goes on to becoming pimples or blisters, or even ulcers. And this can be really anywhere on the body. So it could be, on the face, on the extremities, genitalia, etc. And so if that happens, then you're going to want to get those tested, and we will be sampling those lesions and sending off for a few things. We'll be sending off for monkeypox PCR, also for varicella and herpes simplex. And it is possible to be positive for multiple things. And so you may also be tested at the same time for the usual HIV, syphilis, hepatitis C, and so on. But definitely, at least in terms of those lesions, because they can look similar to herpes, to chickenpox, and so on. And so they would be sampled for those in addition to the monkeypox. And so the basic same things in terms of protecting yourself from SARS-CoV-2, but also more attention to our surfaces, laundry, towels, linens, and so forth. So that's why we are concerned about, hospital staff, making sure that they are using all of the precautions. In this case, we would be considering gloves if we're going to be changing the bed. Let's say if someone where we don't know if they could have it or not, gloves would be in order. And in terms of how to clean our surfaces, the EPA has released a list of disinfectants, but I think the bottom line is the part that I've highlighted here, which is that monkeypox is susceptible to our disinfectants. So this is a big relief. Basically, because monkeypox is kind of a new situation that we're having to deal with, the disinfectants that are on the market now are not technically registered for use against monkeypox. However, basically all of the disinfectants that we're currently using should be more than enough to kill the monkeypox. But if you're really super concerned and you want to actually look up the cleaning supplies, then I've put the link in the post and you can check that out there. But basically, much of what we're doing already for COVID is going to protect you from monkeypox. However, if you are going to be in very close physical contact with someone, you want to make sure they don't have monkeypox. And this brings me to the last piece, which is around the isolation. So it's a little concerning the way that the CDC is talking about isolation. There doesn't seem to be high hopes or firm expectations that people are going to be isolating themselves. It's using a lot of very, relaxed language about you should try, but it might not be realistic. So if you can, so I that's a little bit concerning. But we understand if you're contagious for a month, which can be the case, or even longer, that is going to be hard for most people to isolate themselves. There's a period of time when the rash is present, that we're hearing reports that this rash is very painful. And it's even requiring some people to be hospitalized for pain control. So this is, obviously not a time where people are going to probably want to be going out and about. However, it's when the lesions start to kind of scab over, where you're still contagious. So if you've got a fever, if you're coughing, if you've got open sores, please isolate. I think, we don't want to be spreading this around, and we definitely don't want to be on public transportation or sitting on anything where other people are going to be sitting. If you have open lesions, the CDC talks about covering the lesions, but once again, we don't want a situation where we have yet another out of control transmission of a newer agent. Now we've known about monkeypox for a long time, but the variety that we seem to be dealing with now is different than the one that's been endemic in Africa. So we still do have a lot to learn, and we would like to not see ourselves getting overwhelmed with cases. So isolation is key, and definitely not going out when you've got the open lesions or any active infection. The CDC is also stating that a mask should be worn if a person with monkeypox is going out in public when they're still in the infectious period. So once again, that is going to be a high quality filtration mask that is fitting well. And many of the other points of guidance are going to be the same around outdoors is still safer than indoors, not lingering too long indoors, improving indoor ventilation. This is going to help improve on any kind of droplet transmission that could occur, or airborne transmission that we don't know to what extent this occurs with monkeypox, but we know that it happens with COVID. So we're going to just continue to use these same guidelines, and definitely getting tested for either of these infections if you have symptoms or have had exposure. The vaccine for the monkeypox is still in very, very short supply, but we do have supplies coming into the area. And so right now, criteria are rather restrictive. Most of the county websites have what their criteria are. They're not the same in every county. Some counties are taking a slightly different approach. Often healthcare workers are not included yet. Close contacts, but what is considered close contact seems to be a little bit variable. So a lot of things that are reminiscent of the early days of the SARS-CoV-2 pandemic, where we are short on testing supplies. But the good news is there is a vaccine. We will need it to be ramped up much more quickly than it's being ramped up at this time if we have any hope of getting ahead of it. And so in the meantime, I think we really do need to be a little more have a little higher expectations, I think, around people's isolation. So I think we should be isolating with this because it is contagious, and we don't want we don't want this to get away from us, essentially. And so with children going back to school, this is something we're just going to need to be keeping a close eye on. There's only been one child in California thus far. But again, we're really in the very early stages of even testing. We're not even testing everyone who has symptoms. And so we're doing very focused testing. And this is part of the problem, because if you're only looking in one community, you're only going to find it in one community. So we really do need to be able to broaden this, and we will get there. So hopefully we'll be in time to actually stop this from getting beyond our ability to contain it if it has not already. And so for now, please take good care of yourself, maintain a balanced diet, get some exercise, manage your stress levels, consider a multivitamin supplement with additional vitamin D, and get a good night's sleep. If you have any questions, please submit them in the comments by direct message or by email to admin@rootsclinic.org. This concludes today's People's Health Briefing. Thank you so much for joining us, and we will see you again next Tuesday at 10 a.m.